Hello, ladies and gentlemen. This is the offline recording of my lecture on tooth surface loss. Now, give me 2 seconds to share a screen and my slides, and we can start. Okay, so what I am going to cover at this session for you is to understand the etiology of tooth wear, understand how we can monitor tooth wear, and also talk about how best to manage tooth wear and also when to make the decision to refer to a specialist. Let's start with etiology. And when it comes to etiology, the first thing first, as you know me, I quite like to focus on terminology to make sure that we all speak the same language. So tooth surface loss, or TSL, is non-carious loss of tooth tissue. So sometimes, especially in the south of England, London, instead of TSL, they call it NCTSL. So essentially, TSL, or tooth surface loss, is a normal physiological process and happens in all of us throughout our lifetime. Now, tooth surface loss becomes a disease, becomes pathological if, one, the rate of the tooth loss becomes so fast that it might compromise the survival of the tooth, or if it becomes a concern to the patient. So it becomes too sensitive, or they become concerned or how yellow or how translucent their teeth are becoming. Now, if you look at the Adult Dental Health Survey, which was conducted in 2009, by the way, it was due to be actually done after, but it was just delayed because of COVID. You can see that in adults in the UK, in England, 100% of them have got some form of worn, for some form of wear. 77% of patients you can see wear all the way to the dentin, and 2% all the way to the pulp. And here in Manchester, we definitely see the 2% in our postgraduate clinic. When it comes to categorizing tooth wear, you are looking at these 4 categories: erosion, attrition, aberration, and abfraction. Erosion is when the tooth structure starts to dissolve within the acid. But the most important thing is the acid should not be coming from bacterial activity, because if it comes from bacteria, it becomes caries, so it's no longer erosion. So erosion is when your tooth disappears in acid. And this is an example of the acid attack that you can get in patients. You start to lose morphology of the teeth. And if you look at the anterior teeth, it looks like I prepared them for a 360 veneer or dentin bonded crown. I haven't. This is just what acid, intrinsic acid from the stomach of the patient has done. So as you can see, we've lost morphology, and what you can see as a white ring all around the dentin is known as the ring of confidence. This is part of the enamel, which for a variety of reasons is quite resistant to acid dissolution, and it's fantastic for bonding. So you can easily use adhesive dentistry and bond to this white ring of confidence, or ring of enamel, if you may. Attrition is when you start to experience tooth loss because of the tooth-to-tooth contact. Now, this tooth-to-tooth contact, a lot of times, is occlusally, so it's opposing teeth, but minding you, teeth also, over time, they grind each other interproximally as well. So as we all age, our teeth become narrower ever so slightly and the contacts between the teeth, instead of being round, start to kind of actually flatten out as they rub against each other. So normally, those people who have got severe attrition, this was one of my patients, if you got the top and bottom cast, they fit together perfectly. So because they're grinding against each other, they create a kind of key and keyway effect, if that makes sense. So teeth lock into each other, unlike acid erosion, whereby you lose anatomy. Aberration is where the tooth surface loss happens because of a external object, or external, essentially, factor other than tooth contact causing the wear of the teeth. The biggest prime example is toothbrush. So if people are using hard toothbrush or brushing very aggressively, they can create these V-shape defects in a class 5 configuration on the root of the teeth, which is like pretty much classic for hard toothbrushing. So these are aberrations. So essentially the tooth wear is happening because of another mechanical substance, but it's definitely not another tooth, it's another object. Now, sometimes scientists, they like to put aberration into two-bodied and three-bodied aberration. So in this case, for example, if you're using toothbrush with water over your tooth, you got toothbrush, you got tooth, so it becomes a two-bodied aberration. But if you got toothbrush, an abrasive toothpaste, and a tooth, then it becomes a three-bodied aberration. So if you ever heard about two-bodied and three-bodied, that's what it means. And sometimes, aberration could be quite significant. For example, in this case, you can almost see the pulp on the canine shining through this chap who was a champion toothbrusher. Now, aberration is not merely limited to toothbrushing, and the other objects can also cause aberration of teeth. On the example on the left of your picture, you can see the effect of tongue piercing in creating these abrasive notches on the anterior teeth. And also on the picture on the right-hand side, you can see the effect of an aberration. You can see the effect that the lip piercing has got, causing aberration on the incisal tip of the lower incisor tooth. And by the way, so these objects and piercing is nothing to do with like our new modern sort of lifestyle. There are skulls several thousands of years old, which, for example, in this example shows that this tribal male person would essentially file their front teeth down to make themselves look scary. So when they're going for battles and for the wars, and when they roar and shout, they look quite scary to their enemies. Now, abfraction is the fourth category of tooth wear, which some scientists don't believe in it. So there are books that they only cover the first three categories, and they do not believe in abfraction. Some people do. And essentially, the abfraction is a result of tooth loss because of biomechanical loading of the tooth. And as I said, sometimes people say it's a mystical thing rather than a real thing. But essentially, those people who believe in it, and we do believe in it here in Manchester, is that if you're having excessive lateral forces on a tooth, for example, on a premolar or on a canine, part of the tooth, which is around your CEJ, is fairly weak. And as the tooth is being loaded laterally, for example, on lateral excursions, or if you do have a group function, the part of the enamel and dentin can break off, and they can create very similar type 5 lesions that you would see in toothbrush aberration. The big difference is that a lot of times these abfraction defects they can go underneath the gum, they can go subgingival. Whilst in a toothbrushing defect, you can never get the defect going subgingival, because if the patient is brushing so hard that they can remove natural tooth substance and cementum, they would definitely cause gingival recession. So if you're seeing a V-shaped defect going under the gum, be 100% sure it is an abfraction rather than aberration. And if it's abfraction, the first thing you have to check is the patient's occlusion. Sometimes you have to add to the canines in order to relieve premolars if you're seeing lesions on the premolars. So this adding of composites to the canine is known as canine risers. And if it is the canine which is obviously in too much excessive lateral force, then you're looking at selective grinding of the teeth in order to actually make less of trauma to these teeth. So always remember occlusion if you ever come across an abfraction. So once now we got the terminology right, let's talk about etiology. And etiology is very important in treatment of tooth wear. And if you do not recognize why the tooth wear has happened and what the etiology is, it's impossible to help the patient, because if you don't know what's caused it and you can't stop it or you cannot control it, how are you going to treat the patient? Whatever you do is going to relapse and come back to you. The problem is getting the right etiology is not always possible. Sometimes it's difficult to gain history because patient will willingly withhold information from you. So let's focus on erosion, because that's by far the most common type of tooth wear that you will see in Europe, including England. And as I said, in erosion, a lot of time you will lose morphology of the teeth. So in these examples on your left and on your right, the patient has got acid reflux. And because of the content from the stomach, you can see that in particular, the upper anterior teeth, the platal surface of them are significantly affected. Normally with acid erosion, if they're intrinsic, i.e. coming from your stomach, it's the platal and incisal of the upper teeth, which are massively affected, as well as the occlusal of the lower molars. And furthermore, the platal and occlusal of the upper posterior teeth in this order that I mentioned. So again, if you look at the picture on the left-hand side, you can see the ring of confidence, which is great if you're going to do adhesive dentistry to later on add indirect or direct composite or ceramic material to help protect the patients after you have managed to successfully liaise with the doctor and get their intrinsic acid source, i.e. the reflux, under control. And on the right-hand side, you can see that a very similar pattern. You've got lots of actually wear on the platal, but if you look at the amalgams, it looks like a dentist put all these amalgams high in occlusion. Essentially, this is not the case. So what has happened was the previous dentist made the amalgams exactly where tooth used to be, but acid had dissolved around the amalgam, and that's why they're becoming proud. So whenever you see proud amalgam restorations, that's another very clear sign of acid erosion. And finally, the other appearance of erosion is where you get cupping effect. It looks like small saucers of cavity are created within occlusal surfaces of the posterior teeth, and you can see these cupping effects or saucer-shaped defects, the molar teeth, in both of these cases that are on your screen. So in terms of acid, they can either come from within your body, i.e. your stomach, we call them intrinsic, or they could come from outside of your body, which we call them extrinsic. So let's talk about intrinsic first, and then we touch on extrinsic. So the most common reason for intrinsic acid in the UK is GORD, and 7% of adults, they get reflux every single day, and 1/3 of the adult population in the UK get it, like, from time to time. Now, the same as how you give a patient a diet sheet, if patients go to the doctor in order to investigate their acid reflux, they can give them a diary, a 7-day diary, which is known as the specular. So with the specular diary, it's run over 7 days, and the patient is asked to write down the time of when they get heartburn, how bad it is in terms of severity, if it ever comes with difficulty swallowing, and also if it causes any coughing or wheezing. And believe it or not, in our postgrad department, every year, we kind of diagnose 3 or 4 patients who have got chronic cough. They come to us because of tooth wear, and we realize they do have silent acid reflux. Some people do have acid reflux, GORD, regurgitation, but they don't know about it. And what happens is, especially if you're having the acid reflux at night, the patients can aspirate a small amount of content which is coming from their stomach, and that will burn their essentially the top of their airway, and they keep getting this irritating cough. So as they're talking to you, they just keep coughing like that, and they say, "Oh, it's been going on for like 4 or 5 months, the cough," because you ask about them, are you okay? Well, why are you coughing? And they say, "Oh, the doctor doesn't know what's going on? Give me the blue inhaler and the brown inhaler, and it's not helping. And essentially, you realize that you have a silent reflux, and it's the acid which is causing the coughs. Nothing else. And then a lot of times, as soon as they start the treatment for their acid reflux, the cough disappeared. And as I said, every year we actually find at least 3 or 4 patients who've got this kind of silent reflux and the coughs. Now, the gold standard for make a GORE diagnosis is endoscopy, whereby they put a camera and they will check if there's any sign of acid erosion around your essentially GI tract. And oftentimes they also take a biopsy for your H. pylori bacteria, just to exclude that from the equation as well. Now, endoscopy generally is not a very pleasant procedure. Technology is trying to come in and help. For example, these capsules, which you can take, and they would take a pH measure as they go down, and they actually use Bluetooth to tell the device outside the patient's mouth of, like, in terms of, like, the pH measurement, etc., etc. But it's not commonly in use. So looking at other intrinsic sources, you're looking at any other condition which causes vomiting, and some of the probably more common ones are cyclic vomiting syndrome. And now I put a picture of a baby with content coming out of his mouth. But cyclic vomiting is actually for, it's not necessarily for children. I just didn't want to actually put a picture of an adult, like, having content coming out. But cyclic vomiting syndrome, IBS, motion sickness, migraine, and epilepsy could be all causes. Also, vomiting could be self-induced. The more well-known ones are anorexia nervosa and bulimia nervosa, but also we do have EDNOS, and EDNOS, it stands for eating disorder not otherwise specified, and I will come back to it in a second. Now, anorexia is when patients are avoiding food, and it's quite a complex psychological disorder which will result in severe weight loss. Here are some of your figures and numbers for the UK if you're interested. But what is most important and you need to know is an anorexic patient's BMI should be below 17.5. So if a patient hates food and they're losing weight, but their BMI is not less than 17.5, then they do not have anorexia. They've got EDNOS. So EDNOS is a generic word referring to a patient who is not within a category which is anorexic or bulimic. So an anorexic patient is avoiding food, but their BMI is less than 17.5. If it's not, then they are EDNOS. Now, bulimia, on the other hand, is when people they love food. They don't hate food. They love food and they eat a lot of it, but then they go and compensate and they get rid of the food. And again, here are some of your figures, but most importantly, the BMI of the patient should be more than 17.5. So if you do have a patient who loves food and they overeat and then they go and compensate, but their BMI is below 17.5, obviously they're not anorexic because they love food and they eat food, but then the BMI is not more than 70.5, so then they become EDNOS. So bulimic person has to be more than 17.5. Now, the reason I said that it's sometimes difficult to find out the reason or the etiology for wear is a lot of times patients who do have anorexia and bulimia, they would not disclose this to you, or at least for a long time, until they develop some trust. The other interesting condition is rumination. And some people do have the ability to bring the content of their stomach into their mouth, chew it and put it back. So they are in control of, like, how they put things in and out. Now, if you remember a few years ago in Brit Got Talent, we had this gentleman who came from France, and essentially what he could do was he had 5 coins, and each of them had a number written on them. And obviously in front of 4 judges and 4,000 people, he was swallowing these coins. And then at the end, after he finished swallowing all the 5, he was asking the audience which coin you want to actually bring out, and they shout a number, and essentially whatever number is being called out, the guy magically manages to bring everything out. So this guy's been going around the world in Brit Got Talent and France Got Talent and America Got Talent and everything, just swallowing everything, goldfish, tennis ball, you name it, and being able to be in 100% control of his stomach. But anyway, but this is a photo of him, a still photo of him. And this is a snooker ball, and they're actually quite big. I won't be able to fit one inside my mouse, but if you zoom in, you can actually see that how much wear has happened because of the acid content of the objects that he bring back. So do you think if you go and ask this chap, what do you do for a living? It's just going to say, well, I don't know, I just swallow a snooker ball for a living. So sometimes as a clinician, as a dentist, you have to be very observant of some of the cues that can indicate that the patient has got acid attack from the stomach. For example, the picture on the left-hand side is a bulimic patient, and you can see that they've got this massive hematoma, the red patch, a massive hematoma because of the constant acid erosion coming out from their palates. And it's asymptomatic. They don't have any sign of burning or pain from this, but this is something as a dentist that you will notice. The picture in the middle is the hand of a 17-year-old lady, so very petite, and then obviously very sort of a person that you would never expect to have such a sort of rough hand, if that makes sense. So this callus formation, and it's usually on a dominant hand, is when the patient tries to induce vomiting. After obviously the palate and the teeth, the third part of their body which the acid is going to hit is the back of their hand. So although they are quite young and petite and small whatsoever, they've got very rough, like almost farmer's hand, and it is just because the constant erosion of the acid from the stomach hitting the back of their hand. So this is known as the Russell sign, which is the callus at the back of their hand. And the chap on the right hand side is an epileptic person, and every time people have got grand mal, if they've got major fit, some of the content of the stomach will also come out, and also their parotid starts to produce lots and lots of saliva. And if they do have uncontrolled epilepsy and they're having too many of grand mals in a day, their parotid glands, because it keeps working, becomes very hypertrophic, and you can see how much the parotid glands of this gentleman has come out. So people who vomit a lot, they would actually have very hypertrophic parotid, which is something that you guys need to see. Now, so that's pretty much your intrinsic acid covered. Now I'm going to talk about extrinsic acid, and I'm going to take you for a shopping spree. Now, what I want to do is I'm going to go through some of the drinks that I put on the screen, and I want you to, I know I can't hear it, but on the screen you shout out if you think each of these cause erosion or not. So the first one, starting from the top left-hand side, is Coca-Cola. Does it cause erosion? Yes, of course, it's got erosive potential. Next one is a sparkling water. Sparkling water. Does a sparkling water cause erosion? Shout at the screen. It doesn't. So a sparkle is carbonate, and carbonate acid is not acidic enough to cause erosion unless it's absorbed in large quantities. So just because you got fizz in water, it's not necessarily erosive, if that makes sense. How about a still flavored, sorry, so this is a sparkling, so a sparkling flavored water. How about a sparkling flavored water? Shout at the screen. It is erosive. So as I said, a sparkle is carbonate, and carbonate is weak acid, but flavored are citric acid, and citric acid is acidic enough to cause erosion. So if whenever you got flavor within water or any liquid, then you're very likely looking at citric acid, and citric acid can cause erosion. How about the still water? No, of course. How about flavored still water? Will flavored still water cause erosion? So again, flavor is citric acid, and citric acid can be erosive. So remember, fizz carbonate is not that dangerous, but citric acid, which is the flavor in a liquid, can cause erosion. How about orange juice? Of course, very erosive. How about fruit smoothies? Again, they are erosive. How about dry wine? Dry wine is also erosive. How about beer? Do you think if beer is erosive? Interestingly, beer is not erosive, while cider, again, because it's probably very flavored, is indeed erosive. And how about alcopops, like Breezer? And again, lots of alcopops, they've got tons of flavor in them, as well as the fizz, although fizz is not a major thing, but because of all the flavors, they become quite erosive. Now, let's have a look at some food. How about fresh fruit? It is indeed erosive. How about cheese? Cheese is not. So cheese doesn't cause caries. Cheese doesn't cause erosion. So that's quite a good food to have. The only problem is it actually gives you migraine if you're susceptible to it. But anyway, how about pickles? Yes, vinegar is very acidic. How about chips, salt and vinegar chips? Again, because of the vinegar content, if they do have it, then they can be very erosive. Chocolates, how about chocolates? Are chocolates erosive? Chocolates are not erosive, and obviously they cause caries, but minding you, so the acid coming from bacteria cause caries, not erosion. How about ketchup? Ketchup is erosive, as well as brown sauce. So most sauces that are available in the market are indeed erosive. How about salami? You might guess it, it is not erosive. Now, apart from food and drinks, you can find some of the medications to be acidic, and some medications are acidic via a direct effect. For example, some of the vitamin C preparations, some aspirin preparations, if it's a chewing aspirin, and also some iron preparations. But a lot of medications can contribute to erosion in an indirect effect. For example, they can cause dry mouth, or they can make nausea, and they can make patient vomit. So they're not directly causing erosion, but by removing saliva, which is your defense mechanism, I will come back to it in a second, and also promoting vomiting, which is tons of acid from your stomach, they can be quite erosive or actually contribute to erosion. So people who may have very active lifestyle are also at high risk of erosion. And that's not because of the lifestyle, it's because of what comes with a busy lifestyle. So people who are in fashion, leisure, professional athletes, a lot of times they are using energy drinks to keep them going on crazy hours and like, you know, training, I don't know, parties, you name it. And a lot of times when you're exposed to parties, you would be taking mood-enhancing drugs. Now, majority of the mood-enhancing drugs, they are not erosive per se, but they can cause clenching. For example, ecstasy will also give patients a tendency to clench. And can you imagine patients are probably having alcopops, which are erosive, and then they're clenching. So attrition on top, so they can start losing a lot of tooth surface substance very quickly. Now, in terms of environmental effects, there are some ad hoc, some like, you know, a few case reviews of the relevance of environmental acid onto teeth. I put a car battery. I didn't mean that people who work in the car factory will have that, but essentially the first evidence of erosion from environment was coming from TNT making factories in the World War II. So all these factories were built underground, so the Nazis' airplanes cannot spot them. And therefore, they had no ventilation and no windows. And one of the contents of making the TNTs has got a very acidic vapor, a very acidic gas. And these factories were filled with this fume, acidic fume. And it was known that the workers who were working in this kind of harsh environment, they had no teeth because of the vapor of the acid eroding their teeth away. Unfortunately, at those times, there were no documented photographs of these kind of patients. But what comes to our generation and our years are some reports coming from Brazil, South America in particular, of some or non-standard swimming pools which have been chlorinated with wrong products, so therefore causing a massive increase in acidity of the water, where professional swimmers were practicing, and they were demonstrating what you can see on the right of the picture, which you can see extrinsic acid erosion on the anterior teeth of athletes because of this kind of poor quality controlled water of the swimming pool. And you can see here's another case report from Brazil, and you can see again the mouth of a swimmer, and you can see that it looks like somebody have already prepared all these teeth for some crowns or veneers, and this is generally the effect of the poor quality swimming water and these athletes. So again, I talked a lot about what acid can do to your teeth and where it's coming from. But then the question is, what is our body doing to defend itself against all this acid? Now, so the main molecule which is building your teeth, your enamel, your dentin, is hydroxyapatite. And hydroxyapatite, depending on what strength of acid it is within, it would have a slightly different formulation when it becomes ionized. And if you remember from your biochemistry, you will have a crystal, and then when you got a crystal in a soluble, in a watery, in a liquid environment, it becomes ionized, and this is a two-way equation. So you can see on the top equation on the left, you've got the crystalline form of hydroxyapatite, and then you can see how the ions exist when your hydroxyapatite is in a wet environment, i.e. in your saliva, in your mouth. And essentially, when you have a pH of 7, the solubility of the hydroxyapatite is 30 milligrams per liter, whilst when you drop the pH to 4, it becomes 30 grams rather than milligrams per liter. So that's 1,000 times more soluble. So the way the equation works is that you say per 1 factor of pH drop, you multiply the solubility by 10. So essentially 7 minus 4 is 3. So that's 3. So that's 10 to the power of 3. So that's 10 times 10 times 10. So 1,000 times more soluble. So what saliva does is, so if you remember, hydroxyapatite gets into saliva and it becomes ionized. And if you got acid, i.e. the H will interact with your OH and it will interact with your phosphate. And if you get these out of the equation, more of your hydroxyapatite has to become ionized, and then again, acid takes them out. So what your saliva does is it's full of calcium. So essentially, by injecting calcium into the equation, it pushes the crystalline form, so rather than the ionizing form. So that's how saliva helps in order to buffer the effect of the acid. Also, you do have the pedicle, which is covering all your teeth surfaces. And what it creates a chamber whereby your hydroxyapatite can become ionized and back into crystal, and back into ionized and back into crystal. If you do have lack of saliva, this pedicle forms much later or longer after you brush your teeth. Therefore, as soon as your hydroxyapatite becomes ionized, it vanishes. You swallow it and it's gone. So you actually need to have a bit of pedicle around your teeth to protect your teeth from disappearing into your saliva. Now, after you brush your teeth really well and you remove the pedicle. It normally takes about 10 minutes for your pedicle to get restored, if that makes sense. But if you don't have good saliva, then this pedicle takes much longer to form, if that makes sense. So the other thing is the same as a patient who is susceptible to caries, you give them fluoride. Fluoride binds within the hydroxyapatite formulation to create hydroxyfluoroapatite, which is a lot less dissolvable into acid. So for the same reason that you give patients who are susceptible to bacterial acid, i.e. caries, you give them fluoride, people who are susceptible to acid erosion, You can give them fluoride to strengthen their teeth and stop their hydroxyl appetite from disappearing. So let's move on from erosion now to attrition. And attrition is, before I discuss it, I would like to just clarify these three terminologies. So function is when you're talking about normal movement. So if your mandible is moving normally, then it's in normal function. Dysfunction is when you've got abnormal movement. Parafunction is when you've got normal movement, but too much of it. So you've got normal movement, but abnormal frequency. Hence, attrition goes hand in hand with mandibular parafunction, i.e. people who clench and they overuse their jaw all the time. Because in terms of function, your normal mandibular movement should be only limited to whenever you're eating and drinking. But then if you're spending 6 hours, 8 hours at night, grinding your teeth against each other, then that becomes parafunction. Now, the problem with attrition or parafunction is that, so parafunction is centrally controlled, i.e. by your brain, and emotions can make it worse or actually reduce it, and is beyond conscious control. So unfortunately, you cannot cure it. You just have to keep that in mind and think about, whenever you've done your treatment, how best you can protect whatever you have given to your patients. Sometimes it can be difficult to diagnose. Many patients who may have attritional parafunction, they even don't know about it. Unless you've got a partner who tells them that they grind their teeth at night, they may not know. And also, sometimes they've got good days and bad days, and sometimes they sleep too deep, they will never actually know. And sometimes, parafunction could be intermittent. So they might have a couple of years of no parafunction, and then all of a sudden, things might come back. But as I mentioned about half an hour ago, so when you're looking at attrition, the teeth grind against each other, and therefore you can put them together. So they kind of actually match the pattern of wear of each other. Now, again, there are signs which can help you diagnose parafunction. The picture on the left shows a gentleman who is a champion boxer, and you can see the hypertrophy, i.e. their mesenteric muscles getting very strong. So you can see the mesenteric muscle hypertrophy. You can also see cheek ridging, whereby people unintentionally keep biting where the top and bottom teeth come together, and you see this kind of white line forming between the top and bottom teeth on the cheek, and you can occasionally see fresh or old scars onto the cheek where they have been biting. And the same as how they bite their cheek, they can bite their tongue, and you can get an scalloped tongue, as you can see on the picture on the right-hand side. Now, so when people come to you with wear, they might have a number of clinical problems. They can have aesthetic problems. They can have their teeth showing through too much. They might become shorter. They might become yellower. They might get worried that their teeth are breaking away and keep chipping away. Sometimes they become sensitive as your enamel is disappearing, especially in cases of erosion. Then you will have exposed infantile tubules, and they can have sensitivity to cold. And this can, over time, cause pulpal inflammation, or sometimes in severe cases, you may have even exposure of the pulp. But the biggest problem for us is space, and we'll tell you why. So let's look at this patient from the side. You can see the incisors on the right of your picture and the molar teeth on the left of the picture. So let's say the patient has got intrinsic wear and the palatal surfaces of the upper teeth are affected. Now, Mother Nature does not like gaps. And what happens is, over time, your teeth move toward each other, as well as dragging the gum and the bone with them. This is something known as the dentoalveolar compensation. So here's a patient of mine, which he was in his early 20s. And then I lost him for a couple of years, and he was actually drinking a lot of acidic drinks, and then had a massive episode of GORD. And essentially that's how he came back 2 years later. And he's got a lot of palatal wear. But what's most important for you to note is that how much the front teeth have shortened, but as you can see, there's no space. So if you look at from the canines to canines of both pictures, so the canines are where they used to be, but you can see as the teeth palatally worn down, they move toward each other, and there's no gap. So that's one of the biggest problems that you will face as a clinician, because you lose a space. Okay. Now, let's look into how we can monitor tooth wear. Now, obviously, you're examining the patient, and you would like to every 3 months, every 6 months, when you're examining patient, you take records. The problem is all your examination record keeping can be subjective, and it's very difficult to find objective ways of taking record. Now, first of all, age. Now, is age any relevant to you? Definitely yes, because as I mentioned, tooth wear happens to all of us, and it's a physiologic process. The problem is, how do you know the amount of wear you see in a 20-year-old is acceptable for somebody who's 20? Or the amount of wear you see in somebody who's 35 is acceptable for somebody who is 35. And in all honesty, you can't, unless you've been a dentist for 10 years or so, you've seen thousands of mouths of different ages, and then you create this mental picture to tell you somebody is 40, how much wear and tear they should have. Interestingly, occasionally I get patients referred to me for consultation, and they're essentially severe wear as described by the dentist. And when they come in, to me, it's just physiologic wear, and I don't have to do anything about them. I just like to reassure the patient, reassure the dentist, and the patient actually goes back. And it's one of the things which is like, something you will develop over years and with experience. There are some indices which have been created to try to help introduce a bit of objectivity, and I'm going to cover some of the more famous ones. Probably the most famous one is called Smith and Knight, whereby you're looking at teeth and you're giving them a scores from 0 to 4. 0 when there is no sign of wear, 1 where there's only wear into your enamel, 2 and 3 is when the wear is within your dentin. If it's only minimal, it's 1 mil. If it's more than that, is grade 3. And if you do have any pulpal exposure or you've got more than 2 mil of dentin loss, then you're looking at a score of 4. You also got Kahn and Young, which have got A, B, C, D, E, F, whereby, as you can see, A is for attrition, B is for those kind of saucer-shaped erosions, C is for a cervical lesion, etc. So it's just a way of recording what you can see. And if you want to be very good with Kahn and Young, you can then use color pencils and start penciling things in color in your chart, but good luck finding time in your busy practice to find things. Now, the other famous index to know is the basic erosive wear examination, or BWE. It was suggested by Prof. David Bartlett in London, but it's very limited into only erosive cases. So you cannot monitor attrition or aberration with it. And essentially, you've got 0 for no erosion or tooth wear. 1 is when you just have initial loss of surface texture, and 2 and 3 actually gets more and more severe. And the way it works is you essentially split the mouse into 6 sextants as if you're doing a BPE. You give each sextant the highest score of the worst tooth surface that you can find, and you add them all together. So for example, the patient gets 0, 0, 0, let's say 1, 0, 1. So you add them all together, it becomes 1 plus 1 plus 4 zeros becomes 2. Yeah. And then you look at this table to see if somebody has got 2, then what does that mean? And it's tell you in terms of risk of developing significant wear, and if you have to do clinical management, you can see it on the top, less than or equal to 2, routine maintenance and observation, repeat in a 3-year interval. So it kind of actually, the table gives you an indication of what to do based on the BV score. Now, what you need to notice is what is written at the bottom, and essentially this whole table is suggestion by a single author. So it's not kind of a validated table by a group of experts. So just take it with a pinch of salt. Doesn't mean that BWE is the way forward. And as I say, it's very limited to only erosive cases. Photos, are they reliable? Now, to be honest, let's just have a look at this example. I've got a patient which I saw 12 months before and took some photos, and then I saw the patient again today. And you can see the today and last year's photos. And I want you to take a moment to think about if you think the wear on the platal surfaces of the upper central and lateral incisor has increased or not. Now, the answer is, I was just cheating here. All I did was I picked the same photo, I tilted one and made it a bit lighter and also changed the exposure. and reduce the saturation. So it's exactly the same photo being manipulated in angle and lighting. And all I wanted to do is to demonstrate that if you were thinking there's no change or whatsoever, you probably didn't realize you're looking at exactly the same photo, which has been just photoshopped and manipulated a bit. So be a little bit careful with when you're using photos for monitoring. And it's pretty much like one of these exercises of, oh, can you actually spot 10 different, differences between these two photos and so on, if that makes sense. X-rays, you never ever use X-rays for monitoring tooth wear. You can always use an X-ray if you do have pathology and you do have symptoms to assess, but not for monitoring. The only way you can monitor tooth wear using X-ray is by using micro CT scan of the cast, not the patient. So essentially, you send the casts from 2 different time spans into the laboratory, and they can tell you how much of wear you're seeing in a 3-dimensional way, if that makes sense. The problem is the technology is relatively expensive because it's purely for laboratory studies. And if you want to clinically order this, you're talking about anything between 1,000 to 2,000 pounds. It's quite actually expensive, definitely not worth it, if that makes sense. Having said that, though, we now have got digital technology whereby you can scan patients. Now the video is not working. So essentially, so you can scan patients, and there are some softwares which can tell you if there are differences between 3 months ago and now, and if anything has changed. Now, the most important thing to remember is when you're using digital technology, the softwares, they should have some very solid points in order to be able to reference against each other. So if you're looking at a small amount of wear on select spaces, these softwares can help you, but you're having a lot of loss of tissue, the software gets confused and you will get completely random results. So they only work if you do have localized wear on a very small scale, but not on big sort of cases. Casts, again, looking at cast, it can be beneficial, but you're looking at, first of all, quite a bit of time should lapse so for you to be able to recognize things, and also storing casts is challenging. But having said that, though, nowadays you can obviously scan patients and then print out the cast, so there's no chance of the casts breaking, so you lose your data. But so it's a reasonable way to try. But here's one of our favorite methods to monitor wear. And essentially what we do is we use a putty. And essentially, once you mix the putty together, you make a vertical cut, very similar to how you make a preparation depth gauge when you're doing a crown prep, and you put it on an old cast. If you had one, if not, you take one of the patient today, then save the putty, and then when you see the patient in 6 months' time, then put it back and see if you can see any sign of wear. Now, again, the problem is, one, storage. Second is where you do the section. If you do a section in an area which was not affected, you won't see anything, if that makes sense. So that's a little bit of limitation. So now you have identified that there's tooth wear, you have identified the etiology, and you manage to control the etiology. So how do we manage TSL? So don't forget that when it comes to managing any restorative cases, the treatment planning phases are the same. So you do have the emergency phase, which you have to get the patient out of pain, or if there are any catastrophic aesthetic problems, to deal with them. So pain, a lot of times you're looking at dentinal sensitivity. So you can prescribe them high fluoride toothpaste. You can give them fluoride mouth guards. You can also think about desensitizing agents. You do have Gluma, GLUMA on the clinic, whereby you can just paint over exposed sensitive areas of the teeth and try to help clog the open dentinal tubules. And also you can obviously give them toothpaste for sensitive teeth, for example, Sensodyne toothpaste or Oral-B Pro Enamel. And also if the patient come in with, I don't know, a chipped, fractured front anterior tooth, you can't just wait until you've done everything else. You might have to actually get them out of the aesthetic catastrophe that they're dealing with and then move on to stabilization at your time. So when it comes to stabilization, again, you have to make sure you're risk assessing, risk manage patients for caries, for perio, for occlusion, as well as now for tooth wear. And then once you stabilize the patient, then you go ahead and restore what needs restoring. And then finally, maintain your hardware. Now, let's give you some examples. So this patient was a young patient in their early 20s, and they had a skeletal open bite, anterior skeletal open bite, and they had severe palatal erosion. Now, because the patient had a skeletal anterior open bite, it was not difficult to restore because we hadn't lost any space. So when you're not changing the occlusal vertical dimension, you call it a conformative approach. So this patient was managed in a conformative way by just simply restoring the lost height of the teeth and still honoring the anterior open bite for cosmetics. Because if you close that, you're going to just give the patient a very unaesthetic look. So the only real way to close these kind of anterior open bite is by orthognathic surgery. You don't do them restoratively if they are this big. So this patient had ample of space, and it was quite easy to turn picture from the left to the picture to the right. But as I said, a lot of times you have a space problem, like this patient that you can see on the left of the picture. The posterior teeth are unaffected, but you can see the amount of erosion which has happened to the platal surfaces of the upper anterior teeth. And when you look at the patient from the front, the space is completely closed because of dental-alveolar compensation. Now, so if the space is closed, the argument is if you build up your anterior teeth to their original form, then you're going to cause your back teeth to disocclude. And as you can see on the picture. But so when you get posterior disocclusion, in the same way that you had dental-alveolar compensation in the anterior, you will get exactly the same in the back over time, and your occlusion will reestablish. And this was a concept which was initially described by Dahl et al. In 1970s. So whenever we're talking about Dahl, we're talking about only select number of teeth which are affected, very typically your upper anterior teeth. The rest of your teeth are intact, and you essentially go and restore the form of the upper anterior teeth, leaving a little bit of the gap between the back teeth, and they close together. Now, for beginners, just be very careful how much you're opening the patient up, and I would not recommend you go more than 1 millimeter of opening between the back teeth, the posterior teeth. Anything more than 1 millimeter, teeth start to rotate and they may not come together. So if you're doing Dahl for the first 10 times in your lives, just make sure you do not open the patient more than 1 millimeter posteriorly, if that makes sense. So here's another Dahl example. So we have another patient with wear. So what we do is we send impressions in alginate. You can also take these impressions in silicone or do a digital impression. And then we take a face bow and we send this to the laboratory. If you're using digital technology, you have to essentially use a leaf gauge and ask the patient to use the leaf gauge device to open them up a little bit. You check the posterior disocclusion and then scan the patient in that position. Anyway, so then you send the patient to the lab, or well, if digitally you send your screens, they will do a wax up, either digitally or manually. Here you can see like an analog wax up done in blue wax, so you can see the difference. So then you use your temporary crown material. Essentially what we did was we took a pot impression of the wax up on the cast. We put ProTemp in and we put it inside the patient mouth. So that gives us an idea of roughly how things are going to look like. And if you look at the left and the right, you can see that there is a space between the posterior teeth. And then when you're happy, you turn them into composite restorations. And I will explain the technique later to you. And if you look at this patient, so there is a gap between the back teeth. And if you see the patient 9 months later, all the teeth come together. So if you're doing a Dahl technique, in majority of the patients, you're expecting 7 to 9 months before everything closes. But it's completely relevant to the patient's age, to which teeth you're looking at, how much you open the patient. So if you open the patient only 1 millimeter on a kind of like, young to middle-aged patient, you're expecting around 7 to 9 months for the back teeth to close. So this is how we started, and that's how things come together 9 months later. And all we did was some minimal composite on the upper 4 anterior teeth. So in terms of the technique, if you go on YouTube and you search for composite Dahl, the first video which comes your way with more than 10,000 views is my video. So by all means, go and watch how the technique is done. So essentially, we wax up the teeth, as you can see in this picture. Sorry, let me just go back and see why the video did not play. So we've done the wax up on the back teeth, and then we get putty, and we put the putty on the wax. We get rid of the buccal part of it, and we essentially only the platal part. We check in the patient's mouth to make sure it's nice and stable. We just do some preparation of the teeth just to remove sclerotic dentin and open the contacts. So just to make life a little bit easier for us, here's some PTFE tape going on teeth number 4 and distal. You etch, and then we're isolating every other tooth. And the teeth which are exposed, we put a thin layer of composite at the back of the teeth, and it goes inside the mouth. You light cure it, and then you've got the platal of the teeth formed. So you polish them, and then you repeat the process for the 3 remaining teeth. You etch and bond them, you put the platal part, you cure it, and then you've got essentially 6 platal composite restorations made, like so. And then all you have to do is to go ahead and do the buccal part of these teeth freehand. So as I said, if you just go on YouTube, you can see the high resolution of this video on YouTube, and you can enjoy it. So sometimes, and you remember this patient, which I showed earlier on, if you only do dull, you're not going to correct their gum. These are the areas whereby we look into crown lengthening, or a procedure which I explain to my patients as gum lifting. So essentially I say, okay, your gum looks a bit uneven, so how about we go ahead and do some gum lifting first. So this is the platal view of the same patient. And essentially I decided to go ahead and do some gum lifting. This is only 1 week after the crown lengthening procedure, for me to try to bring those central incisors a little bit close to each other and give the lateral incisors a bit of a better zenith. And then the patient came a week later for me to do some composite work, and I just did this freehand essentially, but I created a bit of a dull effect, as you can see on the back teeth. When I saw the patient 5 months later, those back teeth came together. So all I did was just a very simple crown lengthening procedure and some composite restorations, and essentially restored the patient's aesthetic and function within 5 very short months. Now, the rest of the cases that I'm going to demonstrate to you are at a specialist level. So I just want to show you what is possible, but as a general dentist, you're not expected to carry this kind of actually work. So this is one of the patients I showed you earlier who had a significant amount of attrition. Here are some of the further images of the patient occlusal views, upper and lower, as well as your lateral side views. So what I did was I managed to take the patient into centric relation, i.e. pushing the mandible a bit more distally. And in that condition, then I went ahead and did my wax-ups in an increased occlusal vertical dimension. Now, those lower anterior teeth, although they look short, but I managed to do root canal treatment, and I tried to save them by linking them together using composite. Now, lots of people do not like linking teeth using composite because they say they can develop perio and you might lose the teeth. But what was my other option? To take these teeth out. So I decided to actually give these teeth another 5, 6, 7 years of life before I take them out, because once they're out, 10 years down the line from now, you still preserve bone for this patient. So that's what I did. So I decided to actually maintain those teeth. So this is my mock try, i.e. I use putty over my lab, my lab work, and then I use ProTemp. So I tried them inside the patient's mouth to make sure he's happy. And then when he was happy, I essentially made linked composite in the maxilla and in the mandible. Now, in the mandible, I'm going to leave the composite as they are. And as you can see, I purposefully created some interproximal clearance between the teeth. So a pink or a red TV brush would happily go between the teeth. So the way to do that is I normally use a stent, and then I use a widget, not a wedge, a widget, which is like a very thick floss. And after I've done my bonding, I actually remove the widget so the patient actually can clean after I've done the polish. And in the maxilla, I knew that I'm going to do lots of indirect work. So rather than keeping them separated, I just merge them together because I will be using them as core composite in a few short months. So here's the image of the patient about 4 months down the line. You can see those lower composite restorations have started to stain a bit or hygiene lapse a bit. But in the meanwhile, I gave the patient a provisional denture just to stabilize the patient into this new OVD. And once the patient was happy, I then changed the upper anterior teeth to a combination of single crowns and bridge work. And I finished all the maxilla with fixed restorations and no dentures. And this was the end result for this patient. So I saw this patient for about 9 years follow-up after I've done this work, and everything, touch wood, was going strong until COVID happened. I have not seen the patient since, but for as long as I remember, the restorations were still intact and going. And I know that you guys probably at the beginning were saying this is a stupid idea to save those lower anterior teeth, but hey ho, I got them at least 9 extra years of life, and they were, I don't know when they will be extracted, but whenever they're extracted, actually I bought the patient around a decade of time. So this is how I started. And this is about a year later after I finished with all the fixed work on the right-hand side. And this is how it looks on the maxilla, how we start on the left, and then a combination of bridge work and crown work in place. Here's another case of mine. Again, came to me with a rather deep anterior overbite, but essentially the problem with this case was, so the patient didn't have any skeletal problem. It's just we were missing teeth posteriorly to keep an occlusovertical dimension for the patient. And because the anterior teeth are now overloaded with occlusal loads, that's why there is significant amount of attrition. So again, in this case, so there was a bit of planning. So I did my wax up and I transferred them using temporary crown material. This was my mock try just to see how things looked. And then several visits later, so there's some composite work as well as upper and lower partial dentures. So at this stage, the patient was stable, and I then gave it to the undergraduate students at the time to then make me some upper and lower chrome for this patient. So you can see that, like, how we started and how we finished. And if you initially saw the picture on the left, say, oh my God, it's a very difficult patient. But then if I give you the patient on the right-hand side, it's a very, very simple case. And that's a lot of times what I do also privately, whereby there are dentist colleagues in my neighboring areas, whereby they would have challenging cases and they would like to be involved in the treatment. So I get them stabilized and send it back to them. So then when it is easy for them to, carry on with the treatment. So here's another case of one of my postgraduate students this time. So we had this gentleman who had pretty much everything. So we've got a lack of posterior stops. We've got a significant amount of wear and tear of the upper anterior teeth, and also we've got dental overcompensation. So what we did was we did our wax try for the denture and with the teeth, and we just looked, looked at the central incisor. It just looked awful. It looked really small and stubby. So that's when I had to take the patient back for some crown lengthening, i.e. gum lifting, just to make sure everything looks much, much nicer. So we did the mock try at this stage and everything looked much better. And then it was just like my postgraduate students' work of some composite work, as well as then some chrome dentures in the top and bottom. So that's how we started. And then with some gum lifting, some composite work, and some denture work, that's how we ended up. So that brings me to the end of this lecture. So a couple of things for you to remember. Etiology is the key. So please do not start on treating any of the tooth wear cases unless you know the etiology. Now, I said do not start any restorative work, but you can still do your stabilization phase and emergency phase until you identify what the etiology is and you can get it under control. Sometimes you have to change diet, sometimes you have to change lifestyle in order to actually help preserve your own work. Fluoride in erosive case is important. If they do have any symptoms, your patient, think about how you can desensitize sensitive teeth and take records if you can, as objective as possible, and monitor. And simple localized cases, you can easily do dull treatment if it's simple and localized. But if in doubt, always we are here to help. We are here to guide you. We are here to hold your hand. So if in doubt, always refer. And thank you very much for bearing with me with this lecture. Have a good day.